Hi, I'm Elle. I got a spinal CSF leak from a cortisone shot 10 years ago now, and although I was fixed after 4 months, I went into a condition called rebound intracranial hypotension, and afterwards I've had so many problems, I've actually ended up with 15 brain shunts in 6 years. It's so disabling, however I am thankful that I'm fixed from my leak.
Hi, my name is Tasha and I'm an ER physician. I've been living with a spinal CSF leak for just over 2 years. The cause of my leak was a surgery that was done to remove a benign spinal tumor.
Hi, I'm Jess. I had a CSF leak from 2014. I had a bleb from an intrathecal catheter, but I had surgery in October of 2021 and now I'm finally sealed.
Hi, I'm Carolina and I suffer from a spinal CSF leak due to a labor epidural. I had a bleb which was successfully repaired in a spinal surgery over a year ago, and I am finally living an upright life.
Hi, my name is Sam and I suffered a spinal CSF leak due to spinal anesthesia that I had during my daughter's C-section. I underwent a total of 5 epidural blood patches, the last one being done by experts that sealed my leak. Suffering a CSF leak was by far the hardest thing I've ever been through.
My name is Marta and I have a spinal CSF leak that was caused by a lumbar puncture 4 years ago. And despite having had several blood patches, tried different medication and consulted with different doctors, sadly I'm still leaking and dealing with daily debilitating symptoms that were not there before my lumbar puncture.
Hi everyone and welcome. My name is Bahare Cloutier and I am the founder and the chair of Spinal CSF League Canada. Spinal CSF League Canada is a charitable organization that aims to improve the health and lives of all sufferers from intracranial hypotension caused by spinal cerebrospinal fluid leaks. We strive to achieve our mission through important initiatives. We work 100% on a volunteer basis, and we need your help and donation to continue. So to all donors, thank you. Today's webinar is one of the key initiatives and aims to discuss the clinical characteristics and long-term consequences of chronic iatrogenic spinal CSF leaks caused by medical procedures. On behalf of everyone from Spinal CSF League Canada, I would like to welcome you all and to express our profound gratitude to the chair and the speakers of today's program. They have graciously donated their time on a Saturday to help advance this cause by sharing their knowledge and experience from across the world. Without any delay, I will leave you with the chair of this program, Dr. Eric Massicot, a distinguished neurosurgeon at University Health Network, the Director of Undergraduate Education for Neurosurgery, and Medical Director of Concussion Program, and the Medical Director of Back and Neck Program, as well as a member of the Medical Advisory Team of Spinal CSF League Canada's charity. Thank you and have a great webinar, everyone.
So this will hopefully go very smoothly. I know we have a number of distinguished speakers who have done this before and are very experienced. So my job will be very simple, to try to make sure that we run through the presentations with, sort of a smooth and efficient way. I'd like to remind everyone of a few things. One, this is being recorded for future viewings by other individuals who haven't been able to participate at this time. And the other one is that this is an initiative of the Canadian Spinal CSF League, and it's been coordinated. And this is not their first event. I would invite everyone to visit their website, very well organized and structured. And also, if you're so inclined, to think about donations. So the webinar today will essentially run through a number of speakers, 4 of them, and the selection of the speakers has been very carefully orchestrated to include neurologists, anesthesiologists, and neurosurgeons to cover this topic. We have individuals from Calgary, LA, Stanford, and Bern in Switzerland. So I was going to say good morning to everyone or good afternoon, but it depends on your time zone. So we'll just say welcome, everyone. This really emphasizes the fact that this is an issue that has to be dealt with in a multidisciplinary fashion. The video highlights a couple of very important points. One of them is that the suffering by people is quite significant, and delays in diagnoses and challenges in treatment can often take years. And so this is why we need to bring attention. And I think one of the things you'll find in common with all the speakers and myself is that we're truly dedicated to bringing more attention and education to this so that we can reach more individuals and help more individuals, because this is key. With the right education, the right sort of framing, a number of individuals should be coming for the right treatment in a more efficient fashion. So without further ado, I'd like to introduce Dr. Farnaz Amuzegar, one of the neurologists in Calgary, a lovely lady that I've had to interact with a few times over patients, and it's been always pleasant. She's going to kick off the webinar with her presentation, and I'll turn it over to her. All right, Farnaz.
Thank you very much. Thanks everyone for joining us today, and Dr. Massicott for that kind introduction. So I will start us off with looking at some of the epidemiology of post-dural puncture headache, the diagnosis, and some of the initial management. And then I will let the rest of our speakers take it from there in terms of the more specific anesthesia and surgical management of these cases. So just to start off with, in terms of post-dural puncture headache, it's a complication that can develop after a spinal dural puncture. And this can be either intentional, for example, if a lumbar puncture is being performed for a diagnostic reasons, or it may be unintentional, for example, if there's neuroaxial anesthesia, such as an epidural for obstetrical reasons. The headache is usually orthostatic and can develop usually within a few days following the dural puncture. And commonly, the other associated symptoms might be things like neck pain or stiffness, changes in hearing, tinnitus, photophobia, and nausea. There can certainly be others as well, but these would be the more common things that are seen. So I think as a neurologist, or the first time someone is seeing a patient, whether that be a neurologist or emergency physician, for example, it's really important to ask the patient regarding any spinal procedures when they do present with an orthostatic headache, even sometimes months or years in the past, because these patients can sometimes suffer for headache for a long time before they're actually properly diagnosed or appropriately treated. So it's really important to go back in the history and ask about any potential spinal procedures. In regards to the ICHD-3 diagnostic criteria, so this is the International Classification of Headache Disorders, essentially the Bible that we use for diagnosing all kinds of headaches. What they say is that this headache occurs usually within 5 days of a lumbar puncture, caused by a cerebrospinal fluid leak through a dural puncture. And it's usually accompanied, as we discussed already, by neck stiffness or subjective hearing symptoms. However, they do go on to say that it remits spontaneously within 2 weeks, which, as you will hear, is not always the case. Actually, in many cases, it may not remit spontaneously. And they also say that it should seal with autologous epidural lumbar patch or epidural blood patch. But again, you will see that there are certain cases where the blood patch will not be successful. So even though the statement is there, we do have to take that with a grain of salt and remember that that's not going to happen in all the cases. Fortunately, in the formal diagnostic criteria that you see below, this is not actually in the criteria. So they do say this in the paragraph above, but it's not actually part of the diagnostic formal criteria, which is good. So the headache fulfills criteria for headache attributed to low cerebral spinal fluid, which essentially is a headache that's developed in temporal relation to a spinal CSF leak. Typically, there needs to be either a low CSF opening pressure, less than 60 millimeters, or evidence of leak on imaging. So again, We do have to remember that not all patients with a spinal CSF leak will actually have a low opening pressure. Many will have normal opening pressures, and some might have a leak that's difficult to find on imaging. So we do have to, again, keep that in mind. The other factors that need to meet the diagnostic criteria include dural puncture that's been performed, and headache that's developed within 5 days of the dural puncture. And of course, we always say not better accounted for by another type of diagnosis. So those would be the formal diagnostic criteria. In regards to, what is the incidence and what procedures actually lead to these headaches from occurring? So these are some that are listed. These would be the most common types of procedures, and you'll see the incidences listed there from various papers or the literature. So lumbar punctures can actually be quite a common cause, and depending on the paper that's read or the study that we look at, the incidence can be anywhere from 5 to 26% of patients. And we'll speak to this later as well, but the needle type that's used actually does make quite a significant difference in regards to doing lumbar punctures or other procedures. So that may be why there's some variability in these numbers that we see. Neuroaxial procedures, the incidence has been listed anywhere from about 6 to 36%. So these include things like obstetrical procedures like epidurals. And in the case of C-sections specifically, one of the larger papers that looked at a number of studies, actually, one of the systematic reviews, said that about 23% of cases can potentially lead to post-dural puncture headache. And then there's also regional anesthesia for surgery, but the incidence of that is not well documented. So we don't know exactly how many of those cases lead to post-dural puncture headache. There's interventional pain management strategies that also, again, we don't really know the incidence very well. It's not been well described or documented in the studies, other than for epidural injections, which there was a few studies listing approximately a 2% incidence of post-dural puncture headache. Other things potentially like spinal cord stimulation placement, intrathecal procedures, such as inserting a baclofen pump, those can be higher in terms of post-dural puncture incidence. And then surgeries of the spine as well, of course. So inadvertent dural puncture that can happen. And again, various literature states about 1 to 5% of cases can potentially lead to post-dural puncture headache. What are some patient risk factors now that can lead to this? So there are certain risk factors that make it more likely for an individual patient to actually go on to develop post-dural puncture headache. So the first is actually female gender. And we don't know the exact reason for this, but it seems that, that if you look at the odds ratio, so what are the odds of a male developing this compared to a female? The odds ratio for a male is about 0.55 compared to a female. So females sounds like, overall, they're about twice as likely to develop this. And potentially hormonal factors play a role, but we don't really know for sure why that is. The other thing is younger age. So younger patients tend to be more susceptible to developing post-dural puncture headache. And generally less than 40 years is what seems to be in the literature as being a more susceptible age. The thought is that the dura has higher elasticity when the patient is younger, which makes it more likely to gape when there is a dural puncture, and therefore a leak can happen more likely. We also know that pregnancy can be a risk factor, and that, of course, is partly related to the fact that procedures are done during pregnancy much more commonly for analgesia or other respects. But also there seems to be some thought that increased estrogen levels or vascular tone may play a role in changing the dural elasticity as well. And then if there is a leak that does occur, vaginal delivery can potentially worsen that to some extent. It's thought that the increased CSF pressure during the second stage of labor may actually increase the size of the dural puncture. So that's just something to keep in mind in someone who might have already a spinal CSF leak. And the other things is that we also know that patients that have a previous history of headache, for example, migraine in the past, are also more susceptible to post-dural puncture headache. The other things that have been noted is that if patients already have a low CSF opening pressure, or if they have a low BMI, they're also more susceptible. And the BMI, we do know that certainly the opposite applies as well, in that patients that have high BMI are more likely to develop intracranial hypertension or high pressure. So it does seem to fit that patients with low BMI would be more susceptible. And then there's also the older age population, where if there's more advanced degenerative disc disease of the spine, spinal stenosis, scar tissue, or other things that might obliterate the epidural space, that could also lead to a higher level of post-dural puncture headache. Sorry. So, the other thing to keep in mind is the needle type and size. So there's been actually a lot of literature looking at this, and I'm sure that Dr. Carroll will potentially touch on this as well, but the needle size and shape does seem to make a difference. So we have the needles that are what we call cutting or traumatic needles, an example of one shown there at the top, the Quincke needle. And then there's ones that are felt to be atraumatic or pencil point that you can see below there, such as the Whitaker or the Sprott. And so the atraumatic needles are felt to be better overall to use, and I'll show you some literature in regards to that. And then there's some examples on the right that you'll see there of the pencil point spinal needles that were developed over time, and just with various designs in terms of where the opening might be and where the stylet is. So in all of them from A to D, the stylet is inside, whereas the last one there, the ball pen, the stylet is actually the needle tip. And I haven't seen that one used very commonly, but certainly some of the others are in use. So in regards to, what are some of the procedural related factors that can increase or change the likelihood of developing post-dural puncture headache? And quite a bit of literature has actually looked at this, and there's quite a few systematic reviews and meta-analysis where many studies have been looked at overall. So one of them was a Cochrane systematic review that was done in 2017 that looked at 70 studies and over 17,000 participants. And here they actually found that traumatic needles showed a higher risk of post-dural puncture headache versus atraumatic needles. And that atraumatic needles didn't actually increase any adverse events, because that's been one thought, is that, are they more difficult to use, or could they lead to more problems, in fact? But it's been shown that that's not the case. So there was no increase in adverse events such as back pain. In this particular review, they actually didn't see that there was a difference between the gauges of the traumatic needles or the size that were used, but you will see that later studies do show that that might actually make a difference as well. There was a second systematic review in 2017 that looked at 25 randomized controlled trials. And again, they showed that the pencil point or the atraumatic spinal needles also again resulted in lower frequency of post-dural puncture headache. Or if there was an incidence of post-dural puncture headache, it was lower in terms of severity. And they also found that there was a lower need for epidural blood patches in those cases compared to the studies that used traumatic spinal needles. So the good thing is that even in these cases, even if there is some likelihood of post-dural puncture headache, it tends to be less severe, and patients are more likely to spontaneously improve compared to using traumatic needles. And then another study, a meta-analysis of 57 RCTs with over 16,000 patients in 2018, they found that pencil point spinal needles versus cutting needles, again, were superior. The risk ratio in this case was 0.41 for the development of post-dural puncture headache. And they also found that the cutting needles showed a higher rate of post-dural puncture headache if there was a lower gauge or a larger bore needle in this case. So this one did show that there was a difference in the size of the needle as well. Additionally, there was a more recent systematic review and network meta-analysis actually from just last year in 2021 that assessed spinal needle gauge and the tip design, as well as the incidence of post-dural puncture headache. They also looked at procedural failure, and they found that 11 needles that were compared in 61 RCTs and close to 15,000 patients that were involved in those studies, that the rate of post-dural puncture headache and procedural failure were lowest with a 26 gauge atraumatic needle. So this is really the most highly recommended one to be used based on this large systematic review. However, if that's not available, they then said that the 27 gauge atraumatic needle would be kind of the second choice. And then if a traumatic needle is used, they would recommend one that has a smaller size or a 29 gauge cutting needle. Interestingly, they found that there was no difference between obstetrical patients versus non-obstetrical patients in this study. And participant position also didn't seem to make a difference in this particular study. So for example, whether the patient was sitting or lateral decubitus. However, I'll show you on the next slide that in some cases it can make a difference in another study that they had looked at. In addition, the other thing that's been looked at is the orientation of the bevel of the needle. because it's felt that the dural fibers are oriented in a spinal column in a cephalocaudal orientation, meaning kind of going from top to bottom or a head down to toe orientation, although there's actually some debate about this as well in the literature. However, it's felt that it does make an impact, at least with this larger meta-analysis that was done looking at the bevel direction and the incidence of post-dural puncture headache. This was after lumbar punctures. And in this meta-analysis, they looked at studies that had used cutting or traumatic needles, so the Tui or the Quincke needles. And the bevel was oriented cephalocaudal or parallel when they did the procedure versus oriented perpendicular when they inserted the needle. And they found that in the cases where the bevel was parallel, that resulted in a lower incidence of post-dural puncture headache. So in this systematic review, they found that it was 11% versus 26%, or an odds ratio of 0.29. And this was statistically significant. So it does seem to make some difference. And then going back to positioning, so we talked about this in the previous systematic review, they hadn't found a difference, but there was one done in 2017 here where they looked at intraoperative or post-operative positioning, and they found that lateral decubitus positioning was associated with a lower incidence of post-dural puncture headache versus a sitting upright position. However, one limitation was that they hadn't looked at patients in a prone position, which is also a common position for some procedures. So we don't know so much about prone, but it seems that at least with this study, the lateral decubitus positioning was felt to be better compared to sitting. It's important to treat post-dural puncture headache, not because of the suffering only of the patient, of course, but there's also complications that can happen over time. And what might some of these be? So as we talked about, chronic headache can happen, and you'll see there that some papers actually indicate that up to 20 to 30% of patients who do develop post-dural puncture headache may be left with a chronic headache that can last months to even years. Hypoacusis or reduced hearing, diplopia or double vision, sinus thrombosis or clots in the brain, subdural hematomas or areas of bleeding in the brain, and other things can happen as well, but these are the most common ones. So it really is important to recognize this condition as early as possible and to offer the appropriate treatment. Now, what are some of the treatment options? So again, as a neurologist, of course, we do try to start with conservative management options, but usually if, within a few days or a week, and depending on the degree of severity that the patient has, this may not be successful. So I think it's important to keep in mind that you do need to quickly ramp up if the conservative measures are not successful, especially in the patients that do have more severe symptoms. So in regards to bed rest, there's been some controversy over this in the literature, with some papers stating that it's not helpful at all and others saying that it can be helpful. It certainly does help relieve the symptoms once post-dural puncture headache develops. But previous bed rest before having a procedure, for example, or shortly after doesn't seem to necessarily make a significant difference, but we do know that it helps with symptoms. There's also some literature indicating that abdominal binders may be helpful in some patients, again, just more symptomatically and more of a transient method. Administration of fluids doesn't seem to necessarily help reduce the rates of post-dural puncture headache or help so much even after. One thing that does seem to make a difference and can be helpful, and we do use it in our practice as well, as caffeine. It's been shown to be quite safe overall and effective and can be used up to 300 milligrams per day. And how caffeine works is that it blocks adenosine receptors, which causes cerebral arterial vasoconstriction, which in turn reduces cerebral blood flow, and some of the venous dilatation that can happen, which results in some of the pain. It also helps to increase CSF production, actually, by enhancing some of the activity of some of the pumps, so the sodium-potassium pumps in the brain. The other potential medication that can be used is theophylline, or although there are small studies with this and there are side effects, so we don't tend to use it very often, but it has been shown to be superior to placebo and to acetaminophen. And then other things such as steroids, there's some case reports that it may be successful, but we really don't know for sure. There's no good randomized or large studies in this regard. The other thing that's gained some traction over the last few years is nerve blocks for post-dural puncture headache or spinal CSF leaks. So we can do greater occipital nerve blocks with anesthetic or steroids. Often, though, the effect is transient, sometimes a few days or a week, but on occasion we may get lucky and it may be helpful. Also spinopalatal ganglion blocks, which are shown here in the diagram, where basically there's a block done of the spinopalatal ganglion deep through the nose with a catheter that drips anesthetic materials. But again, short-term relief in most patients. Finally, the epidural blood patch. So of course, this is really where we go to, especially if those conservative measures fail or if patients do have severe symptoms. And I think, again, like we said, a few days at the most, a week or so would be sufficient to try the conservative measures before really looking at the blood patch. And the patients should be followed closely through this time period. So the epidural blood patch is often, but not always, an effective treatment. So you'll see down lower there that in most cases, about 61 to 98% of patients can have full relief of their pain, but it's certainly not all patients. And it involves injecting autologous blood into the epidural space. Again, most of the literature indicates that somewhere around 20 mLs is felt to be sufficient for this particular type of headache, post-dural puncture headache. They've looked at lower volumes or higher volumes, and 20 seems to be generally what's felt to be adequate. But of course, it does change case by case. And many patients do have immediate relief, which is felt to be related to the volume effect of the blood patch. As we talked about, not all patients have successful relief of their pain. And about 20 to 30% of patients are left with chronic headaches. Unfortunately, that can last months or years, or until they're given more appropriate treatment if that is available to them or possible. So typically, if patients do fail epidural blood patches, typically we would try at least a few. Then the next step would be looking at doing some imaging to get some better characterization of the leak. And then surgical options could certainly be entertained at that point. So the take-home points, I think, from this discussion is that post-dural puncture headache is classically an orthostatic headache that develops within a few days of a dural puncture that may be either intentional or unintentional. It's a common condition, in fact. And of the patients that do develop post-dural puncture headache, up to 20 or 30% can actually experience chronic symptoms. So it's not something to be taken lightly. Some of the more common risk factors include the female gender, being younger age, pregnancy, and low BMI. And what we know through the literature is that atraumatic needles are generally recommended because they lead to a lower incidence of post-dural puncture headache, ideally a 26-gauge atraumatic needle. If a traumatic needle does need to be used, the 29-gauge needle would be recommended with bevel in the cephalocaudal or parallel orientation. Initially, we would try conservative management options, but an epidural blood patch is generally a well-established therapy, although not successful in all patients. And if it is not successful, then really looking at those patients with further imaging and surgery. So thank you so much for your attention.
Thank you, Fernaz, for a wonderful presentation and a nice introduction into this topic. I may not have mentioned this at the beginning, but we're going to try to save some of the questions for the end. I'm sort of filtering to the Q&A box and trying to cluster them together. There's been a few very interesting questions, and we'll save them to the end. So without further ado, we'll transition to our next speaker, Dr. Ian Carroll from Stanford. And very well known to CSF sort of leak circles as return presenter. Again, he's showing us beautiful pictures from where he practices. So Ian, without further ado, I'll turn it over to you.
Thank you for inviting me. It's great to be back here among people who have helped teach me a lot about CSF leaks, Dr. Shivank, and through his writing, Dr. Ulrich, and to join friends as well. And I think one of the very first articles I read about CSF leaks was Dr. Amuzagar's review. And so a pleasure to be here with you and to talk about this. One of the things that I've seen is that many people with chronic post-puncture headaches find a significant difficulty is getting their physicians to believe that this can exist, that it's possible, and to be taken seriously when it's 6 months out, 2 years out. And so one of the things I wanted to talk about was what's a differential diagnosis for someone who has chronic post-puncture headache? Can I give you a list of reasons why this happens so that can be shared among patients and physicians, because it's easier to understand that something does happen when you understand all the ways that it can happen. With that, I'll show you this QR code that is a Google Drive folder that I keep and share. Inside that Google Drive folder is a subfolder on chronic dural puncture headaches. It has, I think, what I consider the 9 best articles documenting the occurrence of this problem, and other things like a contact information spreadsheet put together by Duke and Stanford and others for physicians interested in helping people with CSF leak around the world. I'll show this at the end of the talk as well. So with that, let me jump into what I see as 4 principal causes of persistent CSF leak despite a properly done epidural patch. And those 4 things in my mind, and hopefully this list will continue to grow over time as we talk to each other and share images and share experiences. The intact plica mediana dorsalis, I'll talk about what that is, a ventral dural puncture, a dural fistula formation, and a dural bleb formation. And I have this 5th thing down here that I haven't really included in the 4 causes because we don't really know. This has not been documented. We know that you can, during an acute puncture into a vein that's epidural and create an acute little fistula, but we don't know if that contributes to chronic low pressure headache after a dural puncture, at least not to my knowledge. Maybe Wouter will jump in if he knows of a case. So failure point 1 for why a properly done bedside epidural blood patch would not work is what I would call a functionally intact plica mediana dorsalis. So this is a fibrous tissue band that exists in some, perhaps many people, in their epidural space outside the bag. One example is illustrated by this case, a 35-year-old woman who had a spinal tap. After the spinal tap, she had a spinal headache rated at 10 out of 10, had at least 1 failed blood patch. Her MRI of her brain is very unremarkable. She would not meet the old, really current SEEPS criteria. She did not have subdural. She did not have pachymeningeal enhancement. There was no discernible sagging. Dr. Ulrich will look at that and say this is perhaps one of the cases that one of his papers would address. So Dr. Ulrich there, in this paper from JAMA Neurology just a couple of years ago, participated in research that showed some of these distances, the distance between the top of the pituitary and the optic chiasm and the mammalopontine distance here and the prepontine distance here, do in fact increase the likelihood that somebody has a leak if you see those things. And when we look closely at her brain MRI, she in fact met 2 of their criteria for a low mammalopontine distance and prepontine distance. This was the image from the dural puncture that caused her then chronic headache, because I was seeing her 10 years later. I couldn't really tell from this if it was on the left side or the right side of the midline. It's close to the midline, but this isn't a perfectly midline view at that level. When we, in fact, went to patch her, you could see after we put in our needle and injected contrast, that the contrast, this dark hazy stuff here, spread up and down, but not at all to the right side. Often people will have a little kind of fibrous band here. So we put in a second needle here, and that's what it looks like after injecting in that second needle. So this is somebody who needed a second needle on the opposite side of midline to get adequate spread across half the interspace where she had her known dural puncture. And that can lead you to do things like this. This image is from a young woman who had a severe low pressure headache after having a lumbar drain removed. We weren't sure if it was at this interspace or this interspace. We could see a skin suture that showed us where the lumbar drain had been sewed in, and it was at about this level. We started by injecting these needles on the left, and what you can see is we have excellent spread across 3 separate interspaces, but it's all confined to the left side. If this was a bedside epidural blood patch, we'd have great spread on the side that we happened to land on, and none on the opposite side of midline. This is what it looked like when we injected on the other side. We were able to get full coverage. And so some people because of an intact plica mediana dorsalis or other structural reasons, when they get a properly done blood patch, they will just not have spread across the midline, even though they'll have spread up and down across other levels. So a properly done bedside epidural blood patch may do nothing to cover or seal the defect in this circumstance if the defect happens to be on the opposite side of midline. The patient will nonetheless feel better initially with the properly done blood patch, and then their problem will recur. Why is this? So we know that injecting volume into the epidural space without actually sealing or covering a defect pressurizes the bag of fluid temporarily and causes some temporarily remission of symptoms. We've known this for a long time from studies that suggested that epidural saline, simply putting saline in the epidural space, resulted in pain relief for people with post-dural puncture headaches. But of course, it has no effect on sealing the defect. And when they started using blood, it became immediately clear that blood was more effective than epidural saline for post-dural puncture headaches. So there's two things that the patches do. They pressurize the bag, which will happen whether or not your sealant reaches the defect. And then there's a sealing or covering of the defect and sealing the defect effect, which will only happen if your sealant, blood or glue, happens to cover the defect. And so a patch like this, if done with high volume, or a bedside patch on one side, will certainly make the patient feel better temporarily. And then the problem will recur because you didn't actually seal the leak. And so this will lead to a lower long-term patch success rate and artificially inflated estimates of early success. In this case, simply repeating the procedure simply repeating a bedside patch would have given a 50% chance of covering the other side, because you're always trying for the midline and you always land just to the left or just to the right of midline. So the thing to do is to either repeat the patch or to use a bilateral paramedian approach using epidural guidance. Now, this idea that you might in fact have lower long-term success than you anticipate, illustrated by this paper by one of my colleagues, Dr. Flood. She looked at 40 cases of people who had had an accidental dural puncture and 40 controls who had an epidural the same day but didn't have an accidental dural puncture. This was the incidence of chronic headache 12 to 24 months later. And what you see is among the controls, the patients who had a baby and had an epidural but no known dural puncture, the rate of new chronic headache is only 5%. But if you had an accidental wet tap at a major university that was recognized and thought to have been treated appropriately, the likelihood of new chronic headaches was close to a third, 28%. When they broke that down by whether they were given conservative treatment or a blood patch, what you can see is the patients who were given no blood patch had a 40% incidence of headache. And those that had received the blood patch had that cut in half to 20%. It's interesting to me is that, we were taught when I was an anesthesia resident that a properly done epidural blood patch is 90% effective for a post-dural puncture, but it appears to only be 50% effective for reducing long-term complications. And 50% effective is what you'd expect if half the time you land on the right side of midline, half the time you land on the wrong side of midline. The other thing to notice is, remember, the control rate, those who didn't have a dural puncture, was 5%. Even if you were recognized and given a blood patch, your rate of having a new chronic headache a year later is 4 times the background rate. What's failure point 2? The failure point 2 is a ventral dural puncture. So that same woman who in fact had her lumbar puncture 10 years ago, when you looked at the laterals, it looked to me like maybe in fact that needle got to the ventral dura. What I was worried about was that it was this, that the needle had come in from the back, penetrated the dorsal dura, the back part of the dura here, gone through the bag, and then put a hole in the front surface. And why is that important? Because this image was published by Dr. Shivink in his JAMA 2008 review, and it shows how when you do an epidural patch, you may in fact only get coverage of the dorsal dura, which is great if you have a dorsal puncture, and not so good if where you need to get your sealant is here. So you want to do what's called a transforaminal approach, come in from the side to get your sealant here. And that's what it looks like in this patient's fluoroscopy. This needle here was the one putting blood on the back surface, and then we came in from the side, and you can see contrast spreading in the epidural space on the ventral surface here to cover that potential problem. Another case of this was an 18-year-old who was recently transferred to Stanford Hospital for a recognized unintended dural puncture during labor. They had failed 2 epidural blood patches, good subdural hematomas here, little acute on chronic bleeding, some on the other side, maybe a teeny little bit of midline shift. And this is what their spinal MRI showed. And what you see here is the red arrow shows where the dura is, and the blue arrow shows that in front of the bag, there is a ventral collection. The sagittal image doesn't really show, did they do their puncture here or down lower? And that's important because this was now a month later, and the likelihood your patch is going to work a month later is substantially lower. And we wanted to give this woman, especially with her enlarging subdurals, a chance for a definitive repair with surgery. And so we went ahead to try to figure out exactly where the ventral puncture was. We did something called a digital subtraction myelogram, something that was taught to our radiologists by Dr. Shivink and his colleague Marcel Maya, who spent time on the phone with our radiologists. This is what it looks like, and you can see the needles coming in here, contrast spreading in the bag here, and then this little thing here where the contrast was starting to extravasate out, allowing us to localize it at L2-3. You see it there with another image a second later, extending. And that's Marcel Maya there with Dr. Shivink. Again, appreciate their help in teaching us at Stanford how to do this. This allowed a surgeon to go in there, open the dorsal dura, look at the hole in the ventral dura, repair it, and then repair the dorsal dura on the way out. So a properly done epidural blood patch, again, may do nothing to cover or seal the defect. If it's ventral, the patient will again feel better initially after the patch because you've pressurized it, and then recur because it's not sealed, again leading to lower patch long-term success rates and artificially inflated estimates of early success. Unlike the plica mediana dorsalis situation, simply repeating the patch here is unlikely to help. You're not going to land on the opposite side of midline and fix your first failure point. So this is something that's going to require you to either do a transforaminal approach or special imaging to give the surgeon confidence that they should not only explore this, but when they explore it, not just look at the dorsal dura, but open it and go inside and either scope or visually inspect for a ventral dural defect. Failure point 3 would be a dural fistula formation. So patient Lynn, who was a physician, had a venous sinus thrombosis and a venous infarct with hemorrhagic conversion. Essentially, she had a stroke. She had a right frontal craniotomy, evacuation of the hematoma, and had a lumbar drain placement. This is a tube that gets put in the through the dura to allow spinal fluid to escape to reduce intracranial pressure. After a year of having an orthostatic headache, she was worked up for a persistent leak. She had a radionuclide cisternogram, which showed no evidence of a leak. She went to Mayo Clinic. They did bilateral digital subtraction myelograms since her MRI showed no epidural collection. So they were looking for a fistula. They did bilateral digital subtraction myelograms, no evidence of CSF leak or fistula. She had multi-level thoracic epidural blood patches at Mayo without relief. And we went ahead and we suspected she had a leak from the lumbar drain. And this is what we found when we patched her. So this is one of my first patches. The needle is coming in here at 3-4. And usually you can tell, not always, but usually you can tell if you've caused an accidental dural puncture. I was pretty confident I had not caused the dural puncture, but here I am seeing CSF get intrathecal. And I thought, you know, it's certainly possible that that's me, but I think that actually what I'm seeing is my contrast entering the thecal sac from a fistula. But how would I go about establishing that definitively enough for a surgeon to go in there? So we brought her back later, and about a month later, did it again. So there's the intrathecal fluid that entered from the epidural space. And this is a repeat of the patch. This time I've come in deliberately a level below, injected a large volume of contrast in the epidural space to get it to spread up to where I thought the fistula was. And you see this little faint line here that appeared on the digital subtraction images. And that was enough to get our surgeons to go in there, and they found this. This is a hole, but you'll notice the edges are not ratty. They're not unhealed edges. These are not edges that are looking to try to heal themselves if you just cover them with blood. They're well epithelialized, healed edges. This is a fistula. It's not a bleb, doesn't show up on a myelogram as filling with contrast. It led to no epidural collection, but putting a suture in that fixed this woman's problem. Again, properly done epidural blood patch is not going to seal that defect. The patient would feel better temporarily from just pressurizing the bag. Again, repeating the patch isn't going to fix this, and you have to consider doing what I did, which is digital subtraction images in the lateral projection to look for intravasation of contrast. If you're doing this under CT, one of the things you might consider is doing a pre-patch measurement of Hounsfield units in the spinal fluid, and then after injecting contrast, a post-patch look at the intrathecal fluid to see if you can detect subtle evidence that contrast entered the spinal fluid. And then failure point number 4, which I think Dr. Ulrich is going to talk more about, is dural bleb formation. This is my little favorite case. This was a patient who had a spinal cord stimulator placed with a known accidental dural puncture. She developed chronic headaches, and you can see her spinal cord stimulator lead sitting outside the dura there, and right next to it, the dural bleb that caused her to lose 60 pounds as she vomited 9 times a day over the course of 18 months. She's now a med student. That's what it looks like at surgery and with the suture put in it. I think those images might have come from Wouter. Again, that's a patient in whom repeating the patch is not going to fix the problem. They needed a repeat CT myelogram. This wasn't detected on their first. Very fine cuts, often assisted by getting pooled, undiluted contrast to mix here. And you really have to exhaust patching and push for surgical exploration. So I've shown you 4 causes. I'm not going to get back to the CSF venous fistula thing. I do want to take 2 minutes before I close to talk about one more thing. It may not be clear exactly when you've caused a post-dural puncture headache. We make assumptions in our favor about the frequency and severity of post-dural puncture headache all the time. This was a study published by Goldsmith, a prospective cohort study of post-puncture headache in 985 women. And what they identified is that when they looked at these nearly 1,000 women postpartum, that something like 381 had postpartum headaches. They then decided to break them down based on what we know about headaches, about what kind of headaches they were. And you can see, in fact, that the vast majority of these headaches are, in fact, tension type or migrainous or musculoskeletal. You see way down here, only 18 of those 381 headaches, or about 2% of the total, were post-puncture headaches. 4.7% of all the headaches were post-puncture, but it represents essentially 1.8% out of the 985. The point being, almost all of the postpartum headaches were attributed to causes other than post-puncture headache. But when you read their paper, what you see is that they say that although we only diagnosed 18 post-dural puncture headaches, 81 of the 381 women reported symptomatic relief when supine. So for every one patient they actually gave the diagnosis of post-dural puncture headache to, there were 5 others who had symptoms that maybe should have been attributed to post-dural puncture headache, but had migrainous features or other features that sounded like a different kind of headache. And a well-meaning neurologist evaluating them was going to give them an alternative diagnosis. And so I think that this is evident in other papers as well. This is a randomized control trial looking at different kinds of needles to reduce the incidence of post-dural puncture headache. And this I'll just read this from the abstract. The incidence of all headaches during or prior to discharge was 11%. Only 5 headaches, 0.75%, were severe with features of post-dural puncture headache and required an epidural blood patch. So we discount. We don't want to believe that the incidence might be as high as some of the symptoms suggest. And so there's really 2 ways of determining the proportion of postpartum headaches that are attributable to a dural puncture. Method 1 is you take the features you know are associated with post-dural puncture headache, and you count these among total headaches, like orthostatic, postural component. You take the feature you know is associated with post-dural puncture headache, and you count those among the number of total headaches. This is what has been done. The advantage is it's easy. You don't need a control group. The disadvantage is it's based on assumptions, e.g. that post-dural puncture headache will be postural. And the disadvantage is we repeatedly and systematically assign ambiguous cases in our favor. What's an alternative method? An alternative method is you count the number of headaches among those postpartum patients who had a needle in their back. And then you count the number of headaches in a matched postpartum group who had no needle in their back. And then you calculate the excess number and proportion of cases, headaches, attributable to having a needle in the back, independent of what the headache looks like, i.e. you don't make assumptions that only post-dural puncture headaches are going to be postural or vice versa. So you get to count the excess occurrence of headaches, and then you work back from that to determine what % of post-dural puncture headache is postural. The advantage is your conclusions are more reliable and free of bias. The disadvantage is the methodology is much harder. And there's a role here for quote unquote pseudo-randomization. People who wanted an epidural but could not get it because they arrived, for instance, at the hospital too late to receive one before they delivered. The point is, our current methodology is this. The right way of doing it is this, and no one's done this. And so we really don't know what percentage of those 381 headaches are excess headaches that would not have existed had the patients not had a needle in their back. And with that, I will close. Thank you very much.
Thank you, Ian. Excellent presentation. Lots of very good information in there. I'm trying to filter through as many of the questions as possible, trying to address them. A number of common themes are coming through. There's patients that are asking about their particular care, etc. And I think what I'll do is I'll save some of those questions for the end and try to sort of put them together. The next individual I would like to hear from is coming to us from Switzerland, Bern, Switzerland, Dr. Christian Ulrich. Thank you very much for taking the time and speaking to us about this. As a neurosurgeon, he is going to talk to us about the diagnostic and treatment options and give us a little bit about the European and specifically the Swiss perspective. So thank you, Christian, for taking the time, and please go ahead.
Thank you, Eric, for your kind introduction, and thank you to be part of this webinar. It's a great honor for me. So I'm talking about the chronic iatrogenic spinal CSF leaks. This is a diagnostic and treatment options. And this is a European or respectively a Swiss perspective. So I have no disclosures. So coming shortly to the etiology of the CSF leaks. So we have the spontaneous intracranial hypotension, and we all know the different types, which was described by Walter Schiebing. Type 1, type 2, type 3, and type 4, it's intermediated. And we have those iatrogenic CSF leaks, which mean post-dural puncture headaches. And there are also some postoperative CSF fistula and maybe shunt overdrainage, but I won't talk about this. So in the German-speaking countries in Europe, we have some German, Austrian, and Swiss guidelines for the diagnostic and therapy of the post-dural puncture headaches, and also for the spontaneous intracranial hypotension. So these guidelines give some recommendations concerning the diagnostics. And as mentioned previously, they talking about or writing about a typical clinical presentation after lumbar puncture within the five days after. And also there's radiological workup with indirect and direct signs of a CSF loss. So also the goal of the diagnostic should be the exact localization of the CSF leak site. So in PDHD, there is no specific diagnostic strategy compared to SIH. Coming to the treatment, they recommend a body positioning, that means bed rest, some medication, as Fanas already mentioned, doing epidural blood patches, Ian talked about it, and finally, surgery. However, so spinal CSF leaks must be clearly localized beforehand surgery. And this is really a rare condition in many patients with PDHD. So coming to the diagnostic workup, I want to start with the SIH. So as mentioned before, there's a classification described by Wouter Schiebing about 3 types of CSF leaks. So meaning there's discogenic microspur, there might be some arachnoid cysts or a CSF venous fistula. And what is the issue about diagnosing SIH? You have to pinpoint the exact site of the CSF leak. And the diagnostic challenge in these cases is you have a potential CSF leak which can be located along the entire spinal axis, and you have 3 different pathologies to identify. So this is a challenge. So in former days, we started in Bern with this diagnostic workup for SIH. So we had a stepwise protocol that developed during we treated more and more patients. And so finally, we found the reason is in 80% a discogenic microspur and in 20% arachnoid cysts. In these former days, we had the focus on the CSF venous fistulas, but which is nowadays the case. And so we had a good hit rate with this diagnostic workup to exactly see the site of the CSF leak. Now you know where to search, but you cannot visualize the pathology. That is the problem right now, and this reminds me a little bit on Shackleton's on the story on Shackleton's ship Endurance. So the Endurance sank in 1915 in the Arctic, and it was located. It wasn't located until 2022, when satellites identified the ship at a depth of 3,000 meters and only 8 kilometers from the location documented at the time of sinking. And this is almost the same. You know you have to search for something and you know the location, but you can hardly visualize it. So coming back to using the standard diagnostic for SIH in PDHD, and you have different modalities. So the standard will be a cranial and spinal MRI, and the matter is you do not see direct or indirect signs in CSF leak. It is predominantly negative. And in mostly cases have no defect at the puncture site, which is visible. And the dynamic myelography or post-myelo CT, you have to do a lumbar puncture for contrast medium. And this carries the risk that you will have a false positive result for CSF leak due to your diagnostic workup. Coming to the digital subtraction myelography, which is the modality to identify the CSF venous fistulas. This is a very rare condition, in my opinion, in addition to the Pdph. It's really rare, and it only has to be excluded in second line, or that means in refractory cases. So another modality, diagnostic modality, would be the radioisotope cysternography. And this might identify a CSF loss syndrome, but however, the exact determination of the CSF leak site or the anatomical dural defect is right now not really possible. Maybe this, I think this technique will advance and give us a better opportunity to identify the leaks. Coming to the treatment, so we also perform a stepwise treatment approach, starting with bed rest, some supportive medications, blood patches, and finally surgery. And in case of Pdph-D, it's explorative surgery. So an epidural blood patch, how is it working? So I think there are two theories. The first theory is closing the leak by sealing the dural defect with a fibrous transformation. I think this is really hard to achieve. I think the effect of a blood patch is more the epidural compression of the intrathecal volume and therefore decreasing the compliance of the thecal sac. We have a relatively good efficiency on epidural blood patches. It works in around about 70%. Several techniques, which are already was mentioned by Ian. You can do target blood patches, you can do untarget. We do almost in every case untarget blood patches. You can use blood versus fibrin. We always use blood only. So you can use a low versus a high volume. You should at least achieve 20 cc's to 40 cc's as volume. And you can perform ventral versus posterior puncture. But I think in many cases, posterior will be fine, posterior puncture. So what are the indications for surgery in Pdph-D? The common situation is you have an inconclusive radiological workup and you have severe suffering patients. And the psychological aspect is really severe in those patients. So don't get distracted by the psychological aspect, first of all, of the patients, and be guided by a consistent patient's history. And then do multiple previous blood patches that provide at least temporary improvement. And even if radiological workup doesn't show what you'd like to see, and this is a clear dural defect and or CSF egress, indicate surgery in persistent symptomatic cases. So we described the surgical strategy in CSF closure in SIH. And this was also a straightforward concept because we knew the pathology. And we did a small fenestration or a hemidynamic coming from one side. We can open the dorsal dura by rotating the spinal cord under intraoperative monitoring. We can visualize the pathology. In this case, it was a microspur, and you can close it. So strategy repairing the dural leak was quite clear and straightforward. So in cases of Pdph-D, in my opinion, it is really, in most cases, surgical exploration. And so you do not know, in many cases, the exact pathology, and therefore you have to maybe explore three levels, because three levels, that would be that would be the area where the lumbar puncture was done, and I do it with a unilateral interlaminar fenestration, showing this intraoperative picture coming from one side. And you have to explore the visible dural circumference, which is the dorsal part or dorsolateral part of the dura. And so finally, if you can locate your CSF leak, you can close it. But however, so there are various morphologies of dural defects. It was already mentioned, arachnoid bleb, that is circumstances which you can see quite well in the preoperative imaging. So as you can see here, there is a defect in the dura, and the arachnoid is bulging forward. But you can also have, as described by Wouter, a ventral dural leak. In these circumstances, this is a transdural approach, and you can see the nerve root coming out, and there's the small hole in the ventral dura. And you have a basic dural defect. This is a small dural defect, and there's a really thin layer of arachnoid, and normally there's almost no CSF flow during surgery. And you can have real complex dural neosacs, as described in this case report, with a duplication of the dural sac, and so quite amazing what to find during surgery. So next step is taking care of the invisible dural circumference. And this is a part which you cannot see. This is your blind spot. And therefore, I think even if you find a posterior pathology and the diagnostic workup is negative and you cannot identify an anterior leak, just to be sure, I do 360 degree wrapping of the dura with a dura augmentation just to close your blind spot. So coming to the conclusion, diagnostic in PDHD is very challenging and often CSF leak negative. Nevertheless, take the patient seriously. Do not make a hasty psychosomatic diagnosis. Try to narrow down the puncture site by clinical landmarks and diagnostics, and don't miss the indication for explorative surgery. So I want to give some thanks to the Spinal CSF League Canada and all the dedicated patients, my administration and the radiology in my hospital, also my former colleagues from neurosurgery Freiburg and neurosurgery and neurology in the Insel Hospital. Thank you very much.
Thank you, Christian. Wonderful talk. I like the systematic approach. Expected nothing less from someone like yourself. Let's move on quickly to our last speaker. Our last speaker is well known to this topic, and as you heard from the previous presenters, he's been referenced in their presentation. So someone who's been leading the way in this area for a number of years now, Dr. Wouter Shaving from Cedars-Sinai Medical Center. And if we can have the screen sharing, Christian, or we'll let you take.
Okay, I have to stop it. So,
there we go. Perfect. All yours, sir.
Wouter, you're muted.
This was a test. Again, thank you, Dr. Massicott, and thank you, Ian. Thank you for asking me to talk about my my favorite subject, CSF leaks. And I remember pretty well when I was in medical school in the 1980s that one of our neurology professors, Professor von Krevel, was really very excited about having this study published in the Lancet, which in Europe is really, considered the crème de la crème of medical journals. And I never really knew if he was so excited about the fact that it was published in the Lancet or that he was excited about having done this study. And it was an interesting study where he himself did 100 lumbar punctures, and he compared it with or without 24 hours of bed rest. And he found that it did not make any difference. But so that piqued my interest a little bit in CSF leaks. And what was interesting when you read that paper, that's now 40 years ago, is that these people were matched for age, sex, and also what was called neuroticism. And I remember the psychiatry professor who we had said that neuroticism means mainly anxiety and a tendency to complain. And I think that is the same now as 40 years ago. So a lot of patients who have CSF leaks, they're not really being taken seriously. Of course, some patients might have that, but the vast majority of patients just are seen by, so many different physicians. And it literally can be decades before the diagnosis is finally made. So a little bit about nomenclature. So when you talk about traumatic CSF leaks, it's really not just what we call an iatrogenic leak, right? Iatrogenic means a leak that's caused by a doctor. Iatros in Greek means doctor, and previous speakers already have talked about these different iatrogenic type of leaks, but there also are different types of trauma: falls, gunshot wound, stabbing, motor vehicle crashes. And I think it's somewhat important to, use the right nomenclature, but it also can be difficult, right? So this is somebody I operated on a couple of years ago, had many attempts at a lumbar puncture done by a medical student. Now, of course, a medical student is not a doctor yet, so you really shouldn't call that an iatrogenic leak. But vice versa, this is somebody who we had in the hospital earlier in the year. Was a gentleman who was stabbed by a doctor 7 times. The doctor was on drugs, and he stabbed his friend 7 times. And as you can see here on this MRI scan, one of these stab wounds goes right through the spinal cord, and there's a large extradural CSF collection. Now, remarkably, this just healed all by itself without any intervention, just with a week of bed rest. And I think probably that's because he had a self-inflicted epidural blood patch that you can see here that, of course, was right at the site of where the one of the knife blades went through the dura. So that is an iatrogenic leak, but in most series, you wouldn't find something like that. So I think about 5-6 years ago, we started doing these digital subtraction myelograms that Ian and Christian already have talked about. But we started doing it in a consecutive group of patients with post-dural puncture headaches. And in these 27 patients, we found some type of, let's say, abnormality, I think in 9 of them. About half of them had what we call an extensive extradural CSF collection. And about a third of them, I believe, had a bleb or a pseudomeningocele. And then just to get back to Dr. Carroll's point, we did have one patient with bilateral CSF venous fistulas. And when we found that, we were pretty excited because we thought, this is probably a common cause of post-dural puncture headache with normal imaging, which, as Dr. Ulrich has told us, that's by far the most common scenario. But then when we did maybe another 20 or 30 patients with DSMs, we did not find any more patients with CSF venous fistulas. So currently, we don't do DSMs anymore in patients who have otherwise normal imaging in a post-dural puncture headache type of situation. So we also don't do CT myelograms. We really just rely on MRI and MRI myelography. And this is actually a patient from Canada who sent her films a while back. And you can see here on this axial slice, you see the little bleb, the little pseudomeningocele, and on this lateral projection, you see how it's right where the lumbar puncture was performed. And then this is from a different patient, and it's similar to the pictures that Dr. Ulrich showed. So you see the little pseudomeningocele there, that's at lumbar 3-4 level. And then this is, I didn't know that you could call it a neo-sac. I'm going to start using that term. You can see here upon exploration, there's this neo-sac that's really an organized type of connective tissue dome over the bleb or the pseudomeningocele. So you carefully have to peel that off the dura, and just like in Dr. Ulrich's example, there are little nerve roots that are attached to the remnant of this neo-sac. So you have to very carefully take that off the connective tissue band and then reintroduce that intradurally, as you can see here. And then I like to use the number 10 Roten. You can kind of hook that underneath the dura, and that'll give you confidence when you close the dura that you won't inadvertently suture in a little nerve. Now, what about slacks, right? So from bleb to slack, what is a slack? I never use that term, but I know that Dr. Farb likes to use that term, and it stands for spinal longitudinal epidural collection. And as some of the prior speakers have shown, you can also get that from a postdural puncture headache. So this was a young lady who happened to be pregnant at the time with very orthostatic headaches. She had seen many doctors. She was diagnosed and treated with POTS. And she came to our hospital, so one of my colleagues, Dr. Chu, and he said, wow, it really sounds like you have a spinal fluid leak, which was not that surprising because she'd had many procedures done, lumbar punctures, LP shunts, for a diagnosis of pseudotumor or IIH. And then on her MRI scan, you see this extensive ventral collection, the slack, and then you can see that on the axial plane, it's actually causing some spinal cord deformation or displacement at least. And then on the DSM, you can tell where exactly the lumbar puncture was performed, or the placement of the LP shunt, I'm not sure. And then, as we've seen previously, that's what it looks like under the microscope. There's like a tiny little hole. Now, this girl had symptoms for at least 4 or 5 years. Now, she was pregnant, so we didn't really want to operate on her. Dr. Maya did some blood patches. She felt good for a couple of months. She delivered her baby, and then in the postpartum period, we went to the operating room. So what about postdural puncture headache? So I haven't really heard anybody talk about what's the best way to treat that is, of course, by preventing it, right? I think that's really important. And how do you prevent postdural puncture headache is just by not doing it. And I think, certainly as neurosurgeons, we don't think about that too often. But when you are involved in the CSF leak world, you do think about that a lot. I think from the North American, or at least the US perspective, the number one reason for performing an unnecessary lumbar puncture is a medical legal reason. And I remember when my son was 2 years old, and I was a resident in neurosurgery in Minnesota. He had a fever, and he was, a little lethargic, and we took him to the ER. And then, they insisted that he needed a lumbar puncture. And I said, I had just immigrated from Holland. And I said, you know what, I'm not going to sue you if he's got meningitis. I really don't think he has meningitis, but they really wanted to do it. They were able to do it after many attempts. But what I still can remember vividly is when they were done with the lumbar puncture, which actually was done by a neurosurgery resident because the pediatrician was not able to get CSF, is that he had literally hundreds of little petechial hemorrhages all over his body. So I thought, this is really something you only should get if it's really necessary. So we looked not that long ago at a large number of patients, hundreds and hundreds of patients, where we compared CT myelography to heavily T2-weighted MR myelography for patients evaluated for spontaneous intracranial hypotension. And we found that doing the MRI scan was not inferior to performing the CT myelogram. So we actually haven't performed CT myelography for about 10, 15 years, and we really rely on MR myelography, including in patients who have post-dural puncture headaches. And I think I was kind of blown away by this article that was published a couple of years ago in Brain, and they found that actually you should expect somebody to have a CSF leak after a lumbar puncture. And they performed MR myelography in maybe 60, 70 patients who had a lumbar puncture done, and they found that 2/3 of patients get a CSF leak, sort of to be expected. They found a CSF leak in everybody who had a post-dural puncture headache, but they also found it in more than half of patients who did not have a post-dural puncture headache. Now, of course, these MR myelographic studies were performed, if I remember correctly, within 24 or 48 hours after the lumbar puncture. This is just a case that I share a lot with our residents. He was a 27-year-old, and I was on vacation, I believe, and his father was emailing me, "Oh, my son, he became paraplegic, and he has had trouble since he had a lumbar puncture." So he had a lumbar puncture when he was visiting his grandparents in Vegas at the age of 10, and it was similar to my son. It also was done to rule out meningitis. But when you talk to the dad, it really didn't sound like meningitis. He didn't even have a fever. He was just, he just had a headache, I believe. So they did the lumbar puncture, and ever since the lumbar puncture, he'd had headaches. And he had been evaluated at some places in the US, and he was told that he had a big spinal cyst in his thoracic spine, but it was not related to his headaches. And then when we saw him, he actually had one of these slacks, these large ventral collections that you can see here on the MRI scan. The digital subtraction myelogram showed exactly where the lumbar puncture had been done 17 years ago. So this unfortunate man had been suffering with a leak for 2/3 of his life. And then at surgery, you can clearly see there's a little tear that was caused by the lumbar puncture. It was very straightforward to repair, just a little figure of 8 suture. And postoperatively, the ventral collection was gone. And in the PECU, he started moving his legs again. The paraplegia was completely functional. It was not related to his actual leak, but he had been suffering for so many years that he felt the only way he could get attention was by feigning paraplegia. This is another example, somebody who lives in Orange County. That's the county just south of Los Angeles. And what was interesting is that her post-dural puncture headache did not start until a month after the epidural. And most of the time, when somebody has a persistent leak after an epidural, you don't see it on imaging at all. In this particular case, you could see it, as you can see here on the digital subtraction myelogram. This is where the dural puncture was done, and then it leaks out into the epidural space. And then I'll just talk a few minutes about, something that we see a lot in spine surgery programs. That's the post-op pseudomeningocele. Here you can clearly see where it is. It's very clear. At surgery, there's a tiny little hole there that you can see there. It's super easy to repair just with some sutures. And I think whenever you have a post-op patient who's had spine surgery with a headache, it's really a CSF leak until proven otherwise. And I just put these two pictures in just to remind me that, to tell you a story about a patient I saw maybe 10, 15 years ago, famous movie director here in town, had spine surgery done at a different hospital, and he'd had headaches ever since, were gone when he would lay down. His internist had referred a patient to me like a year prior, so he knew a little bit about CSF leaks, but the neurosurgeon said, you know what? I didn't see any CSF during surgery. It cannot be a CSF leak. I think it's from high blood pressure. And the patient says, oh, but I don't have high blood pressure. And the neurosurgeon actually went to buy a blood pressure monitor for the patient to see if he had high blood pressure. Well, he didn't. Finally, he came to see me in the office. This was like 6 p.m. The office was really closed. He came to my private office. I did not have a bed in the private office at the time, but he was so sick, he had to lie down on the floor and he vomited on the carpet. So I took him to the operating room the next morning, and he told me that the neurosurgeon actually called him the night before saying, don't have surgery with sheathing, don't do it, because I found out he's not going to put in a lumbar drain after surgery. And a lot of people use lumbar drains, nothing wrong with it, but I just don't think it's really necessary. I just use Diamox, which is a good medical substitute for a lumbar drain. Anyway, the surgery was super simple. It required a single suture, and he was fine. This is another example of how things can go a little bit wrong. This is a 15-year-old boy with Costello syndrome. He'd had a scoliosis surgery done in a different state. Surgery, the mom and dad were told, went perfect. The day after surgery, he started having bad headaches. Nobody picked up on it. 2 years later, he finally sees a neurosurgeon, does a brain MRI, says, oh, you've got a Chiari malformation. Now, mind you, the brain MRI that was done prior to the scoliosis surgery did not show a Chiari. Anyway, he ended up with a Chiari decompression, wasn't any better. And then he went to a different institution where they did a syringo subarachnoid shunt because he also had developed syringomyelia. And during that surgery, they found that he actually had a big leak. They removed one of the screws that they thought he was leaking from, but they couldn't really find it because they went around the dura, and the extradural approach did not show where the leak actually was coming from. And then this is some imaging that we obtained. You can see the syrinx here. He had developed superficial siderosis. This is now after 4 years of leaking. Here you can see where the screw that had since been removed had gone through the dura. You can see some of the hardware, and then this is the dural hole. Now, I'll just also talk a few minutes about what we see much more common, which is post-dural puncture headache with normal imaging. Much more difficult thing to deal with. And when I looked at this recently, really turns out that when you do exploratory surgery, at least when I do it, only about 50% of patients are helped by that. And it's independent of what I find at surgery. So whether I find absolutely nothing or I find an actual dural hole, the results seem to be exactly the same. So I think if you wanted to go ahead with surgery, you kind of have to set the bar high, right? So don't, if a patient says, oh, I had one blood patch, I want to have surgery, I really wouldn't do that if imaging is normal. You have to have a close working relationship with a good headache doctor, because maybe there's a different reason for the headache. Like I said before, we only do MR myelography in that situation. And then at surgery, you can suture it, you can clip it. I oftentimes use a dural graft, Durarepair it's called, which will seal to your own dura after 4 to 6 weeks. And then for a while, because of some people had said, oh, maybe there's an inadvertent ventral breach of the dura, even though you don't see it on imaging. I did exploration of the ventral dura and a little bit of dural reduction, but actually never found any ventral tears. All right, thank you very much.
So thank you very much. I think all the speakers did a wonderful job. I'm sort of a little bit distracted because I'm trying to look at the Q&A box here and trying to address some of the questions. I've written down some of them here, just trying to cluster them. The first thing I'll say is that there's a number of questions in there that are clearly coming from individual patients who are asking questions about their specific management and what they should be doing and what they should be telling their doctors. We have to remember this webinar is about education, and it's about sort of global sort of sharing of information between different specialists and different jurisdictions. So, each of the speakers spoke very eloquently about their experience and how they do it. But again, you have to keep that in mind, that we're not doing this to treat one specific individual. And there's maybe a number of circumstances in your care that need to be considered. Having said that, part of the objective today is to raise the awareness and bring attention to all of this topic. And maybe in your jurisdiction, I think one of the questions was, do you know anybody in the UK or specifically in Scotland that can help me? You have to kind of look around, and identifying individuals who have expertise in this can sometimes be very challenging. So we can try to address some of these questions, but we're not going to be treating any individual patient here. So having said that, there's some questions with regards to imaging, and I'll throw this out to the speakers. There's some questions with regards to comparing nuclear studies and myelograms. And when do you sort of do myelograms, and when nuclear studies is a good substitute? I heard some comments about not doing that many myelograms and just really focusing on MRs and the different sequences. So maybe some thoughts from the speakers on, how do you see, the use of imaging? Because some of the other questions were, are we at a stage now where we can stop doing such invasive imaging, such as myelograms? Because myelograms are very invasive. We're putting a needle in, we're flipping the patient practically upside down and flipping them on their sides and doing it multiple times to really identify that leak. So let me stop there. And the topic is imaging, nuclear studies, myelograms, MR sequences. What are your thoughts?
Well, I think, particularly in people who have a post-dural puncture headache, you really should try to avoid another lumbar puncture, right? And I think that's one of the reasons that sometimes surgery is not successful, because you might know exactly where the lumbar puncture was done, but it's possible that they're now actually leaking from where the CT myelogram was done. Or, oftentimes they'll have, 3, 4, 5 CT myelograms. So we really try to go away from invasive imaging. So we rely on MR myelography. We really haven't done radionuclide cisternograms for at least a decade, because I think it's not that helpful. It's really almost useless for identifying the exact site of the leak. There might be something to be said for, in a really difficult situation, that the cisternogram might be able to sway you. Oh, does this patient really have leak symptoms or not? Or are there symptoms from something else? If there's poor progression of the radionuclide over the hemispheres. It's just that I think, like I showed you that paper in brain, more often than not, greater than 2/3 of the time, you will get a leak from the lumbar puncture. So when you look at large series of people who have cisternograms done, and they'll say, oh, look, we found a leak, you'd see that 80% of those leaks are in the lumbar spine. And I think those are just leaks that are caused by the spinal needle that's used for the cisternogram. But, other people do it differently. And I know there are some places in the US who very much rely on cisternography.
Walter, I agree. So, can you hear me? Or yeah. So I think additional invasive diagnostic workup is not necessary in those patients who do not have any epidural CSF collection. And so in most cases, without any epidural CSF collection, you will do myelography or nuclear cisternography. You will have an additional puncture, and you cannot be sure if it is iatrogenic, the CSF leak, or if it is an original CSF leak. So therefore, I really only use myelography if there is a CSF collection, epidural. And so I want to to see if I can define the exact site of CSF leak. If not, so I only use MRI, try to see any dural defect, such as bleb or some neosac, something like this, and then I go for surgery.
Yeah, as the other neurosurgeon on this webinar, I don't feel comfortable doing exploratory surgery, and I was interested in your comment with regards to half of the time it doesn't seem to make a difference when you go and have a look. So I kind of tend to push for the myelogram, and really, and I work with Richard Farb, so I go back to Richard and say, find me the leak. Without a very specific leak, I'm not. Now, this is with the spontaneous ones, the ones with a history of pseudomeningocele. Maybe the story there is obviously a little bit different, and the MR images and the different sequences can typically point to where the defect is. I like knowing whether I'm going to have to sort of open the dura and go through and repair the anterior part of the dura, or is it all sort of posterior? Even laterality can make a difference. So for me, that's kind of where the bar is. I need to identify a leak, and really, unfortunately, the technique for that is the myelogram. That's kind of where it's at. Maybe moving on, there was a lot of questions about the epidural blood patches, and some of the questions were in respect to symptoms. So after the blood patches, some patients experience worsening of symptoms, or more back pain, radicular pains. And maybe this is one for Farnaz, your experience in dealing with patients who've had this, and maybe Ian can chime in as well, because, the two people who do blood patches. But what has been your experience with patients and their symptoms with EBP? And the other part of this that I'll throw in is with rebound headaches and some of the symptoms surrounding that.
Yeah, for sure. So in regards to blood patches, of course, done for both spontaneous as well as the post-dural puncture headaches, we do find that there is a good percentage of patients that do have some back pain afterwards. Less likely radicular, I would say, in my experience. Often it's more musculoskeletal, where they just have some sort of ache and tension that's there for a number of days. But most of the time it does go away. I don't find that I've had many cases where it's been long lasting, fortunately. And in the cases where they might be a little bit of radicular pain, obviously we collaborate with our anesthesia colleagues and have them assessed to make sure that there's been no concern. That way we do examine them. They often will do a neurological exam if they see the patient or myself on call, if they do come back within the sort of first few days after a blood patch with issues. And in some cases, we have had to use some pain medications or analgesics like NSAIDs, or, in rare cases, something like gabapentin, which is a neuropathic pain medication. But in most cases, fortunately, there hasn't been any major complications that I've been aware of at our site, at least. And Ian definitely can speak to this much more, having done a lot of them. In regards to rebound intracranial hypertension or high pressure headache, this is relatively common, I would say, actually, for any type of procedure that closes a leak, whether that be blood patches, fibrin glue, or surgical procedures. So I think it really, you have to take the time to take a good history from the patient and determine that that's what's going on, first of all. You really have to look for those features that are often the opposite of the orthostatic headache, right? So they often feel worse when they're laying down. It's often a headache that's first thing in the morning. And they can have other associated symptoms like visual symptoms, transient vision loss, or double vision, diplopia, or pulsatile tinnitus. And often we will, if it's more severe or more rapid progression of that, sometimes we will image them to ensure that we're not dealing with a complication like a venous thrombosis. So they may get some CT or MR imaging. But otherwise, we do treat them similar to any type of high pressure headache using Diamox or acetazolamide, but with careful monitoring and follow-up, because a lot of them will improve over days or weeks. So we do have to kind of be careful that we're not also overdoing it with the Diamox. So just gradual start, gradual escalation as needed, and then gradual tapering with close follow-up. So that would be our experience here in Calgary. Ian, I don't know if you probably have more to add with the blood patch, given your experience.
I would say with the blood patch, back pain after a blood patch, very common for the first week, even really the first couple of weeks, then seeming to improve in the vast majority. I think if I had to guess, I would say probably there's something like a 1% rate of people reliably saying, yeah, you know, I had new or substantially worsened back pain after epidural patching that seems sustained and clinically significant. Clearly can happen, clearly happens at a low rate, whereas early pain after the patch is very common. And in fact, I would say radicular pain after the patch is very common. So it's clear that blood on nerve roots is irritating, and people will get a sense very commonly of discomfort going down their legs. If I'm doing a high volume lumbar patch and they say I'm getting, you know, some pressure down my leg, I'll typically, you know, give them some time and ask them if it's feeling better, and then work in a little more and work in a little more blood. So the simple occurrence of some radicular symptoms when I'm in the lumbar spine doesn't usually stop me from necessarily giving them more volume. Very different when I'm in the thoracic or cervical spine, where I'm not just worried about putting a little pressure or irritation on the nerve roots, but the cord itself, which we don't want to put any pressure on. I've had one patient that comes to mind who had very clearly worsened long-term radicular pain following a patch. And the same person I saw in follow-up recently, totally fixed from her leak, totally fixed from her headaches, which had been chronic. And I asked her, you know, did she feel, you know, all things being equal, would she rather have not had the patch and not been treated? And she happened to feel that she was better off for it, that she could manage the radicular pain with the combination of a TCA and a gabapentinoid. But I mean, you know, when you have one patient like that, it sure makes you think very seriously about what you're doing and why you're doing. With regard to the rebound high pressure, I think it's clearly a problem. Dr. Shivink has published stuff he can talk about in terms of preoperative or pre-patching imaging, suggesting who's at higher and who's at lower likelihood in terms of venous sinus dimension. And we continue primarily to manage those again with Diamox, topiramate, potassium citrate to prevent kidney stones. And recently have had two patients with long-term rebound who appeared to be feeling better with a GLP-1 agonist, with this class of medications used in diabetes that appears to show good effects in reducing intrathecal pressure in animals. So I'm now aware of two patients who have had long-term rebound that seem to have benefited from that. We'll see. They're still early on in it, just months rather than years. So we'll see if that winds up being helpful. Doctor, do you want to chime in on rebound?
Well, a couple of things. You know, we used to think if a person got a rebound headache after a treatment, we thought, oh, that's a really good sign that proves that you had a leak. That, of course, is not the case, right? So particularly in post-dural puncture headache patients, if imaging is all normal and you do a blood patch, a lot of patients will get high pressure headaches. And I think the reason for that is that either there is no more leak or the leak is just minimal, right? If you or I would get a blood patch, especially if it's done high volume, we would definitely get a high pressure headache lasting for a few days. You know, Diamox is a great medication for high CSF pressure headaches, but it has a lot of side effects. So we usually start with dandelion tea. 2 cups a day is all you need. Apparently, it doesn't taste that good, so you also can get capsules.
Yeah, this really emphasizes the fact that the CSF dynamics, the production, the absorption, and you throw in a leak and you throw in some changes between the cranial and the spinal compartments. we have to pay particular attention and realize that this is a very dynamic process, and there's physiological factors that weigh in. There's a number of other factors that we have to put into the equation. One of the comments in the Q&A box was with regards to the size of the leak or the size of the dural tear. And I have to remind the listeners that for the most part, we don't really, and I love the pictures, that were shown in the presentations, with the dural tears, and how really have a way, unless we go and do surgery, to go and see those tears and see how big they are. But in my experience, the size of the dural breach does not always correlate with the symptoms. And again, this feeds into the conversation about the idea that the amount of CSF flow that works through and how your body compensates for that. I think that plays a bigger role in some of your symptoms. Question regarding arachnoiditis, and this I'll open up to other people. There's a concern that the coexistence of arachnoiditis and CSF leak, and how do you tell the difference, etc. This individual had a number of questions that kept coming up with regards to arachnoiditis. My experience with arachnoiditis in these cases, and again, arachnoiditis is a very important entity, but as a surgeon, it's not something that I can do much about with regards to treatment. Obviously, when we do intradural work, we want to minimize the chance of development of arachnoiditis, so cleaning out the intradural compartment and making sure there's no blood products or anything that'll create an inflammatory process. Any other comments from the panelists with regards to arachnoiditis and what they've seen in managing patients?
I've had a few cases now where patients who've had repeated blood patches or procedures of the spine unfortunately have developed it, and it can be very debilitating, unfortunately. And like you said, there is really not kind of an option that works for everyone. But what we found is that high-dose steroids, such as IV Solu-Medrol or methylprednisolone, usually over the course of a few days, along with neuropathic pain medications like gabapentin or pregabalin, can be helpful, but that these patients can have long-term effects. Unfortunately, I have a young patient who's developed this, and even at the best, she's got pain on a daily basis that kind of interferes with her day-to-day activities. And then for whatever reason, she gets flares of pain from time to time, and we do have to unfortunately go to the high-dose steroids to try and settle things down. And sometimes, imaging can be helpful for that, because there are features on MRI that can be helpful to help distinguish it from other factors. But in her case, actually, the imaging wasn't fully supportive either of the diagnosis, but clinically she does fit well with that diagnosis, and has significant radicular symptoms and back pain and paresthesia. So it can be quite debilitating.
The only thing I would add is we at one point made a video posted by Stanford to YouTube on the treatment of nerve pain, which talks, I think, in a lot of detail for lay people about what we understand about nerve pain and medical treatment options. And arachnoiditis would be kind of a classic case of nerve pain. And so for those interested in learning more about the medical options that might be overlooked by a primary care doctor, I would direct their attention to go perhaps look at that video.
Thank you. No, that's very helpful. It's a challenge. It's a challenge as medical practitioners. One of the comments in here that was made was with regards to how can we raise awareness to obstetricians and other individuals who perform these epidural procedures, to raise awareness that this actually happens more often than they realize it. The other thought was with regards to our pain specialists. As we see this explosion of pain clinics, certainly in Canada, this is something that's definitely on the rise, and their threshold for doing injections seems to be getting lower. We're going to see possibly even more. And that's why some of the literature that Farnas presented, was quite uncertain. We don't know what the incidence is, because I think it's an evolving field and we need more information. But certainly making sure that our pain colleagues, our pain specialist colleagues are aware of this and not have them kind of go off into their area and not be cognizant that this is a possible complication that has quite serious repercussions. The other question that was put out here was with regards to an association between CSF leaks, either post-lumbar puncture or otherwise, and connective tissue disorders. And the one that often comes up here is Ehlers-Danlos syndrome. Any thoughts from the panelists with regards to those two entities?
So in my patient, I really rarely see a proven Ehlers-Danlos or Marfan syndrome. It is so some patients are hypermobile. They can they have some tissue hypermobility, but so it is really rare condition that the Ehlers-Danlos or Marfan syndrome is really diagnosed, in my point of view. But there are a lot of case reports mentions this. Yeah.
There was a Dutch neurosurgeon who published about a decade ago that in people with spontaneous leaks, even if they didn't have Marfan or Ehlers-Danlos, they were much more likely to show on physical exam stigmata of benign joint hypermobility and other stigmata of connective tissue. He's here on the panel somewhere. But to my knowledge, nobody has done that same thing with persistent post-dural puncture headaches. And the same methodology could be used to say, if you looked at people with persistent post-dural puncture headaches and compared them either to healthy controls or controls who had a dural puncture that resolved, are you more likely to find things like joint hypermobility? I don't know that it would really change that much. I mean, would women with known joint hypermobility not get epidurals when they had their childbirth? My experience is people are very resistant before they have a problem to doing concrete things in anticipation that they might have that problem. I think that we are not built well for prophylactic, for as health systems wise, we often look for prophylactic things because they're cost effective. Individual wise, we tend to avoid things that that might uncertainly have a prophylactic benefit from a problem we don't believe we will ever have. But with that, I'll let Wouter speak to that.
Well, I think you're definitely right about making that point about prophylactic healthcare, not just in this situation, of course. But I think, I do think patients with Ehlers-Danlos syndrome, and, I'm not talking about the classical syndrome where you have a type 5 collagen mutation. I'm more talking about the much more common, just patients with a high Beighton score with joint hypermobility, for which there's no genetic mutation that's ever been identified. And what, Dr. Carroll mentioned, we did write about that. We had a geneticist from Israel who looked at a lot of patients that we saw during his fellowship here at Cedars. And it did seem like that was very common, but we never had a control group, right? And then I think there was a study in cephalalgia from Taiwan where they did have a control group, and things like joint hypermobility, there was absolutely no difference between patients with spontaneous leaks and patients with headaches from other sources. The only difference is that I think it's called dolichostenomelia or something, where you have really long arms compared to your height. That was the only significant difference in patients with spontaneous leaks versus the control group. And I think, a lot of joint hypermobility problems, it's such a heterogeneous group of patients, it'll take some work trying to figure that all out. Unfortunately, at least as of now, there's not reliable type of animal model to look at, the dura, integrity of the dura, things like that. And certainly, like Dr. Ulrich said, Marfan syndrome, we often talk about that, but it's like less than 1% of patients we see with spontaneous leaks.
Can I ask a question?
Please.
This is a question I've posed to Dr. Shivink just recently, but I'd be interested to hear Dr. Ulrich and Dr. Massicot's thoughts. When I see the pictures of these dural defects that are well epithelialized after a microspur or something like that, and we hear about how sometimes with these punctures, the results, while very meaningful, I think, you take 50% of people who are living with a chronic leak and you fix that 50%, like that's well worth doing. But is it possible, and to what extent do you think it might be contributing, the epithelialized edges of these defects? Is there a role for roughing up the edges, maybe scraping the epithelium off the edges before sewing the defect closed to maybe enhance? I see. What are your thoughts about that?
As delicate as I think I am during surgery, when you go and put a stitch through it and you close it up, I don't think I need to rough up the edges, because there's going to be scar tissue that's going to happen around that area as well. So even, I just did a case last Wednesday, and Richard had told me, okay, you're going to find a leak. It's going to be here, and I found it. And while I'm repairing this leak, I sort of always scan up and scan down, just, having a look around, making sure the intradural compartment is nice and clean. And I found another spot. And like you say, it was well, I mean, this gentleman had symptoms for, if I remember correctly, at least 3 years. So chances are the edges of that are not going to be rough. It's not going to be something that just happened a few weeks or months ago. And so the epithelialized sort of edges and the chronicity behind it certainly was suggestive. But I think that, we go in there and we kind of put the stitch in and we close it and we think it's a nice watertight seal. But really, we're also relying on some degree to some of the scar tissue from the surgical intervention that we do. So going in and roughing up the edges, I don't think is really necessary. Christian, I mean, what are your thoughts?
So yes, so normally in some cases the different layers, dura, arachnoid, really stick together. I try to separate the layers so to get the anatomically correct layers together, and so I do not cut any edges from the dura or to have new cells growing in. So depending also on the size of the leak. So in for example, the classical post-punctional leak, this is a very small leak, and in some cases dura is very thin. So I try even to avoid to use stitches, because I am afraid of making a new CSF leak. So in those cases, I use a patch more likely. I prefer a patch, and so patching is also some kind of risky, because your patch can loose, and therefore I use the mentioned 360-degree dura wrap. So you can finally fix all around the dura the situation, and it cannot dislocate anymore. So separating the anatomically correct layers, that's in my opinion, very important. Using, not in all cases, suture and the dura wrap.
Great. So I'm sensitive of time. It's already 2:00 here, Eastern Standard Time. So we've been at this for a full 2 hours. I think one of the last questions I'll ask is if the panelists are open to having patients contact them directly to, ask about specific care, pathways, etc. I can tell you that in my case, we are in the process of developing a formal intake process for people with CSF leak. Right now, it's just, a question of sending an email and we redirect it to our local neurologist, etc. But I think, if you're interested in an opinion from Dr. Carroll, Dr. Shevink, Dr. Ulrich as well, but I think you're a little bit out of most people's jurisdiction. But if you guys are interested in taking on questions, we can certainly work through the Spinal CSF Leak of Canada. You can send your inquiries there. For those of you who I didn't get to their questions, I apologize. We broke the 100 mark questions on the side, so I tried my best to answer as many of them. If you don't have answers that you're happy with, then certainly forward them on to the organization, and we can try to address them post-webinar. On that note, I'd like to thank everyone for their participation. I think this was a wonderful activity, which hopefully will elevate the overall knowledge about this entity and hopefully improve the care of all of our collective patients. Thank you.